Thank you very much, Dr. Lee, and welcome everyone. Thank you for joining us here today. I want to thank Ash for highlighting quantitative decision analytic work. Our lab is the first in the country in classical hematology to be doing work in this space, and it is a privilege to present to you this abstract, which will be presented as an oral tomorrow, entitled Gene Therapy Equity in Sickle Cell Disease, Distributional Cost-Effectiveness Analysis of Gene Therapy versus Standard of Care in Patients with Sickle Cell Disease in the United States. About a year ago, Gina Collada in the New York Times published this article, Pioneering Gene Therapy Freed this particular patient, Helena Bondo, of her disease. Quote, is a cure at hand. When you think about gene therapies and the gene therapy space, you think about a rare neurologic disorder here at the very top, spinal muscular atrophy, pricing at $2.1 million. Thalassemia at $2.8 million. Hemophilia B, just recently announced at $3.5 million. Question becomes, what would it be a fair price, so to speak, to put on therapy, gene therapy specifically for our patients with sickle cell disease, knowing that this is a particularly unique patient population. It's a patient population that's been historically marginalized in our country. So, cost-effectiveness analysis conventionally does not capture the impact of health inequities, but distributional cost-effectiveness analysis does. This is a new methodology out of the University of York. We are the first to apply it in the hematologic-oncologic space. Briefly, equally distributed equivalence is an important concept here, and so the question really becomes what completely equal distribution is equivalent to the unequal distribution of interest. And the question is, what disparity do you care about? Do you care about socioeconomic status? Do you care about the social construct of race? And so the data here is decades old, but the Atkinson-based formulation of EDE is in front of you. You don't need to know or remember the formula. The reason I point it out here is I just want to show you where the inequality aversion index comes into play. Number one, this is not a linear relationship. We care about the population size at hand, and we care about the health in each group. Again, the health could be the health in the lowest socioeconomic strata. The health could be in a certain patient subpopulation that you're interested in. So the question is, what is the decision maker's value of this value? Epsilon. And in brackets at the bottom here, I put for you epsilon of 0 implies no weight on equity, meaning that we really don't care about equity considerations. We know from income studies in the 1970s and 1980s that the prior US estimates put this value roughly at 0.5 to 3.0. So knowing this, we can actually proceed to back calculate what a fair price would be for any given therapeutic in any given space for any health inequity that we care about. So this is an analogy. Who would accept a more equitable but less cost-effective option? And who would pay for a more effective but costlier option? And so at the very bottom here, I put the country flags for and the incremental cost-effectiveness ratios for what we know are the typical standard cutoffs in the different countries. And it's a similar component with equity. And so which society as a whole and which inequities is it that we care about? So specifically for gene therapy, if you look at it conventionally, so if you look at your typical cost-effectiveness analysis, gene therapy is quote-unquote cost-ineffective. So what does that mean? I'm going to get to the right figure in a moment. On the left, you see what is called the state transition diagram. And so here, on the left, SOC means standard of care. On the right, gene therapy is gene therapy. We have patients with sickle cell disease who can either have mild, moderate, or severe sickle cell disease. We wanted to make sure that the analysis reflects clinically a patient population that is truly eligible in clinical trials. And so that has to reflect the age, gender, ethnicity, race adjusted estimates. And so here you can see, see if I can use this arrow, it's not coming up here. So on the left, essentially, you can have patients going from mild to moderate disease, and this is defined again based on the definition that we use in clinical trials in terms of number of hospitalizations for vaso-occlusive crisis. And so, in any given year, using 10 years of claims data, we can think about in any given year, a patient had a mild disease, maybe the next year they had moderate disease, and the next year it could have been moderate again, or it could have been severe. It's really a transition matrix that goes 9 ways. And so at any point too, they can die, right? They can die from sickle cell disease, so disease-specific mortality, or they can die from background mortality that is not specific to the disease. And so then we introduce gene therapy. And we assume, this is a significant assumption that we can talk about in the Q&A period, we assume, theoretically for now, that gene therapy is going to be 100% effective in these patients, meaning that their mortality will be brought down back to their age and gender and race ethnicity adjusted background mortality. And so on the right, you have an ICE scatter plot. So on the x-axis is the incremental effectiveness. On the y-axis is the incremental cost. And really the big thing here is the dashed line that you see running across with that slope. That's the willingness to pay in the United States of $100,000 per quality adjusted life year. You see all 10,000 simulations of doing and giving these patients gene therapy, all of them, everyone who's interested and who's eligible with mild, moderate, or severe disease. In all 10,000 simulations, gene therapy is cost ineffective at an ICER of $178,000. You see the confidence interval next to it. However, if you start to think about health equity component, so we show that utilizing this distributional cost-effectiveness analysis component, i.e. equity weights, that the threshold epsilon for these patients is about 2. If you remember, this is the reason why I showed you what has been traditionally accepted in the United States. The epsilon derived in the 1970s and 80s that is US specific and focuses on socioeconomic inequities is 0.5 to 3. And so here in front of you, you have the x-axis, which is your net health benefits, and the y-axis. At the very top, you have an exacerbation, so worsening of disparities, and on the very bottom, you have reduced disparities. And so this is how we can think about this concept in a two-dimensional space. And we're really looking for that slope, that epsilon, where the EDE of gene therapy is equal to the EDE of standard care. So before I show you the results in the sensitivity analysis, to amplify that point one more time, that the relationship is not linear, what does it actually mean practically, for our patients, for the public, for stakeholders? So an epsilon of 2 implies that one quality adjusted life year gained by a patient with sickle cell disease is equivalent to 2.91 qualities gained by a patient without sickle cell disease. And an epsilon of 1, you can see here, implies that 1 quality gained by a patient with sickle cell disease is equivalent to 1.68 qualities gained by a patient without sickle cell disease. And again, our epsilon here is 2. So this is a DCEA 2-way sensitivity analysis. It's heat map color-coded to make it pretty. On the x-axis, you have the inequality aversion parameter. On the y-axis, you have gene therapy price. And if you actually take the established inequality aversion parameter, another word for that is inequity weight, and you go and say, okay, 0.5 to 3, what is the corresponding gene therapy price? And so that is what you'll see here. This is just the 2-way sensitivity analysis for the women, and you can see that that price point can go just a little bit north of $3 million. So this is the first distributional cost-effectiveness analysis evaluating gene therapy versus standard of care in individuals living with sickle cell disease. As far as we know, it's the first DCEA in the hematologic-oncologic space as well. So while gene therapy, and this is the important point, may exceed conventional cost-effectiveness standards, if we actually care about equity and under the distributional cost-effectiveness analysis threshold analysis and use the typical equity weights in the US, we can see that this could be truly an equitable therapy for our patients. Last point, which is important, is that future studies to determine these equity weights across diseases and health disparities, if this is where we want to move to as a field, if this is where we want to move forward with in clinical medicine in general, if we care about equity. So those are the kinds of studies that can help inform equitable and value-based price benchmarks going decades into the future. So with that, I want to say thank you to my co-investigators. This is truly a Yale Medicine, Harvard School of Public Health collaboration. Those are unusual, and so I want to highlight that. And of course, highlight all of the fantastic people that I get a chance to work with and mentor, and my institution for supporting me, and my collaborators. Thank you very much.